Good evening. Okay, I just want to make sure everybody is awake and fine. Thank you for the opportunity. I congratulate the organizing committee for a great conference. I think the delegates registration has gone beyond 1,500. I think we should give a round of applause for the organizing committee. Well, the topic they've given me is hypertension in diabetic, new evidence and new guidance. I have nothing to disclose. My agenda of the talk is going to be introduction and what causes hypertension in diabetes, impact of hypertension on diabetes mellitus, special characteristics of hypertension, guidelines, target BP, various trials, management strategy, antihypertensive combination therapy, and conclusion. As you know, hypertension plus diabetes, the cardiovascular risk increased by threefold. Hypertension is associated with 57% of increase in all-cause mortality in diabetic patients. How common is this duo? Hypertension is twice as common in diabetes. The other way also, the new onset of diabetes in hypertension is 2.5 times. So anybody who's got hypertension, you must also look for diabetes. And anybody who's got diabetes, you should look for hypertension. Of course, only 1/4 of the hypertension in diabetes is controlled. In type 1, the hypertension is due to nephropathy. In type 2 is predominantly due to insulin resistance. The diabetic nephropathy is the cause as well as the consequence of the hypertension. What causes hypertension? There are so many theories. Metabolic syndrome, mainly insulin resistance, endothelial dysfunction, excessive RAAS activity, endocrine causes for both hypertension, Cushing, Cons, and drugs causing both hypertension and diabetes. Hyperinsulinemia can enhance renal sodium reabsorption and vascular reactivity. Angiotensinogen from fat cells can increase angiotensin 2 and thus blood pressure. Hyperglycemia stimulates intrarenal production of angiotensin 2, which again increase salt and water at the proximal tubule. The additional factors favoring hypertension diabetes is increased sympathetic tone, endothelial dysfunction associated with hyperglycemia, AGEs, increased free radicals, and altered response to nitric oxide, genetic factors. Of course, normal insulin action, there is a balance between sympathetic activation and the vasodilatation, so there is no increase in pressure. In obesity or hypertension, insulin resistance, there is potential sympathetic activation, there is attenuated vasodilatation. Because the balance is not there, there is elevated blood pressure. The hypertensive patient usually exhibits more frequent insulin resistance, more hyperinsulinemia, dyslipidemia, microalbuminuria, obesity than non-hypertensive patients. Of course, impact both on microvascular and macrovascular, renal, coronary artery disease, stroke, retinopathy. Diabetes and hypertension, 6-fold greater risk of developing end-stage renal disease when compared to non-diabetic. Diabetes increases the risk of coronary events 4-fold in women after menopause. Certain special characteristics of hypertension in diabetes. This is the normal circadian rhythm. Any hypertension in diabetes, not only a diabetic hypertension, even ordinary people who are having hypertension without diabetes also, I would suggest at least once in their checkup, they should undergo ambulatory blood pressure monitoring. Because ambulatory blood pressure monitoring, in most of the physicians, they don't advise, but if you do ambulatory blood pressure monitoring only, you will know certain features. For example, this is the nocturnal dip, is a circadian rhythm normally we see, and this is the early morning surge. This is normal physiology. In hypertension, you see the early morning surge is exaggerated, the nocturnal dip is also not there. So this is stage 2 hypertension, reverse dipping and morning surge exaggerated. So this is what you get it in diabetes. So any diabetic hypertension, you should do ambulatory blood pressure monitoring to see whether the patient has got nocturnal hypertension. And the nocturnal hypertension, if the patient has got, as ADA recommends, one of the antihypertensives should be in the night. So lack of nocturnal dipping in arterial blood pressure has been demonstrated both in type 1 and 2. The lack of nocturnal dipping is associated with increased risk of stroke, myocardial infarction. So nighttime BP control becomes especially important in diabetics. Even if you cannot do ambulatory blood pressure monitoring, I would request you to advise for home blood pressure monitoring. I am very happy to see all the endocrinologists, diabetologists aggressively promote home blood sugar monitoring. We have got 14 days home blood sugar, etc. but you are not very much interested in advising for home blood pressure monitoring. So for the last 3 years, I had been talking to more than 100,000 physicians and doctors, requesting them to promote home blood pressure monitoring, which is very important to control the blood pressure. If you ask me which is more dangerous, whether it is diabetes or hypertension, hypertension is more dangerous. So control of hypertension is very important. One of the factors which help you is the home blood pressure monitoring. Overall BP variability, again, there is a terminology called BP variability, just like glycemic variability. Blood pressure variability also is increased in diabetes, and fasting sugar is major determinant. Autonomic disturbance, arterial stiffness also contribute. Increased 24 hours blood BP variability predicts coronary artery disease in diabetes. Nighttime systolic blood pressure variability is independent risk factor of coronary artery disease. More than that, visit-to-visit variability also was significantly associated with all-cause mortality independent of mean BP patients. So you should see the record, how the BP varies, and especially if you give a home blood pressure monitoring, ask the patient to bring the records and see if there is more variability. That's the patient who is going to have problems. The new understanding of the increased risk of hypertension, diabetes related to early vascular aging, more or less pronounced arterial stiffening, chronic inflammation, insulin resistance, endothelial dysfunction, and shorter telomere length. Pulse pressure is a marker of increased arterial stiffness. An association was described between pulse pressure and shorter telomeres in diabetes. Again, one more interesting feature is excessive salt sensitivity and increased extracellular volume. The blood pressure of diabetic patients is more sensitive to salt intake, and this sodium sensitivity is found even in the absence of nephropathy. A decreased salt intake is important for diabetic patients with hypertension. And diabetic hypertension and nephropathy, increased systolic pressure is a significant risk factor for microalbuminuria and rapid progression to nephropathy. It is also strongly related to the development of micro and macrovascular disease in diabetic patients. And this is how you should check the pressure, because many a time we don't check the pressure in the clinic, only the nurse will do it. So it's better you must tell them how to check the blood pressure, otherwise that will also give a wrong value. And in diabetes, you must take postural, postprandial and ambulatory BP, because autonomic neuropathy, one may have postural hypertension. And these are the guidelines which says if you see diabetes, the target is 130/80 in Canadian, China and Taiwan. And in European guidelines is 140/85. And API, when I was the president of the API, we formed a guidelines and we said 140/80. Of course, now the target levels are changing. There is a very solid evidence of beneficial effect of reduction in macro and micro, greater versus small blood pressure reduction type 2, as demonstrated by HEART trial, UKPDS trial, confirmed by ABCD's trial. Previous guidelines such as J1C7 identify lower blood pressure goal of 130/80 in patients with diabetes, supporting the lower is better. And this is the increased risk of cardiovascular complications. If the patient has got 10 millimeter decrease, there is a definite reduction of myocardial infarction, 21%, 44% reduction in stroke, and 56% reduction in heart failure. Again, this heart study says if you reduce the diastolic pressure, the incidence of cardiac events are less. And major CV events from intensive BP reduction in diabetic patients, 24.5 blood pressure diastolic is more than 90, 18% if the blood pressure is more than 85, only 11.9 if the blood pressure is around 80. Again, the CV mortality risk doubles with each by 20/10 millimeters of BP increment. All of you know, if the patient develops, if somebody has got 115/75 and they develop 135/85, compared to that patient, there is a double the risk of cardiovascular event. And the systolic blood pressure also increases with men with type 2 diabetes, and that also correlates this by the MRFIT trial, the multiple risk factor intervention trial. And these are the studies which define the goals of blood pressure. I don't think you should see all that, because it will more confuse. The more and more you read about the trials, the more and more confusion you have about the target. Inverse trial says higher incidence of death in patients with intensive control. Accord trial was the one which was a eye-opener, where the intensive glycemic control and intensive hypertension control had a lot of adverse events in group. And so many trials roadmap trial, target trial, HOT trial, UPDS trial. What does these trials say? How far we can lower blood pressure? The most notable trial used in considering systolic blood pressure goals is the Action to Control Cardiovascular Risk in Diabetes ACCORD trial. This study has been a source of commentaries and discussion about how far to go with BP lowering. This study examined cardioprotective benefits of intensive blood pressure lowering as compared with standard therapy 130 to 139 in high-risk patients. What do they say? There is significant benefit in the secondary endpoint of stroke, but no serious adverse events were significantly higher in the intensive group. No changes were seen with regard to renal function or other microvascular complication. So in the JAMA February 10, 2015, MDIN and colleagues report the most detailed analysis to date to the relationship between BP lowering and macrovascular. They analyzed more than 1 lakh patients with type 2 diabetes where 10 millimeter of reduction of systolic BP lowered from conventionally adopted elevated baseline of 140 or greater to systolic range of 130 to 140 was associated with relative risk reduction of 13% of death, cardiovascular events 11%, retinopathy 13%, albuminuria 17%. So initiating BP lowering therapy in diabetic patients with high normal BP and a target of systolic below 130, there are not much benefits, evidence are scarce. The recent reappraisal of ESI guidelines also says the BP goal should not be reduced more than 140. For diabetic patients, it's always better BP less than 140/90 and close to 130/80, but not below the value. So you remember this only. You don't have to read about all the trials because each trial gives each different opinion. And the ADA 2017, the same like what last year, blood pressure should be measured at every patient routine visit. Patient found to have elevated blood pressure should have blood pressure confirmed on a separate day. Systolic target, again, they say it should be treated as systolic blood pressure goal of 140, less than 140. Lower systolic targets such as less than 130 may be appropriate for certain individuals at high risk of cardiovascular disease if they can be achieved without undue treatment burden. Similarly, diastolic target was less than 90, and if you want to reduce to less than 80 if they're younger patients and people can tolerate. And pregnant patients, the 120 to 160, 80 to 105 according to ADA. So diabetics derive more benefit from the same degree of blood pressure lowering than those without diabetes. So what is the target finally? A lowest blood pressure which a patient can tolerate without suffering side effects like postural hypertension, without compromising arterial circulation and as well as the quality of life. So what is the strategy for management? Proper blood sugar, achieve target level of blood pressure, early detection of both diabetes and hypertension to prevent complication will improve the quality of life. The patients with BP 120/80 should be advised on lifestyle. Patients with confirmed more than 140/90 should, in addition to lifestyle, should be put on to pharmacotherapy. And non-pharmacology therapy, never underestimate the role of lifestyle modification, weight loss, sodium restriction, exercise, smoking cessations, moderation of alcohol. And of course, weight reduction can reduce to 5 to 20. DASH diet. Here I would like to emphasize, we always say DASH diet will reduce 8 to 14. And the DASH diet, one of the important things says is everybody should take 4 times servings of vegetables and fruits. How many of you take 4 times vegetables and fruits? Can you raise your hands? 4 times fruits and vegetables. Hardly 3, 4. We preach, we teach everywhere, DASH diet, we say, we read also, but none of us follow that. So I think the drive home message for my talk here will be, if you go back and tell your people and family to take at least 4 times vegetables and 4 times fruits, it is good for not only diabetes, good for your health. So this information you must say, because we always tend to take fast food. I always say fast food takes you faster to the grave. And antihypertensives, of course, there are a lot of drugs. How many minutes? 4 minutes, okay. The ideal antihypertensive drugs must decrease blood pressure, must reduce RAAS activity, must prevent, improve or arrest proteinuria, must prevent and protect CAD, CKD, favorable on glycemic control, improve dyslipidemia, must not worsen peripheral arterial disease, improve erectile dysfunction and not cause impotence, must not decrease EGFR, must not raise uric acid or serum potassium. Should be combined with other drugs and should not increase insulin resistance, well tolerated, cost effective. The general principle of treatment, it has been recommended that all patients should receive either ACE or ARB, there is no contraindication. Multiple drug therapy is generally required, aspirin therapy in ADA recommendation, statin therapy also. And the therapy and the target needs to be individualized for each patient depending on age, comorbid conditions, cost factor, socio-psychological factor, metabolic profile, and renal function. According to the other various guidelines, JNC 7, 8, American Heart Association, European Heart Association, Canada, all of them invariably advise ACE and ARB as the first line drug, and AAC, a constant statement that angiotensin converting enzyme inhibitors and ARBs are associated with favorable effects on renal function and may improve insulin sensitivity, making them as the ideal first choice in treatment. Of course, the UKPDS trial, HOPE trial, ABCD trial, all proves that ACE inhibitor is better, and these are the benefits and reductions of cardiovascular events. And why ACE inhibitor is better, improves insulin sensitivity, reverse LVH, it produces cardioprotection, renal protection, prevents future diabetes. And the ARB's trials are renal trial, REMARK trial, identity trial, detailed trial. All these trials prove that ARB is also good drug, and telmisartan is a PPR gamma stimulator, so it is also very good. A beta blocker, generally we don't use it because of masking of hypoglycemia, prolonged hypoglycemia, worsening of hyperglycemia, less protection for nephropathy, increase in insulin resistance. Only two, three drugs, beta blockers, are insulin not resistant. One is carvedilol. All the other drugs are, it produces insulin resistance. So withholding beta blockers, is it advisable? Especially in diabetes mellitus with coronary artery disease, doubles their mortality risk. So beta blockers do have the role if the patient has got coronary artery disease. And of course, in CAD, demand angina, we do metoprolol, carvedilol. There are selective cardioselective drugs in sympathetic activity where we give bisoprolol and other vasodilatory beta blockers. Diuretics in diabetes, isolated systolic hypertension, we can use indapamide is preferable. Calcium channel blockers, non-dihydrogen calcium channel blockers, when beta blockers cannot be used, we can use it. The long-acting amlodipine or calcium channel blockers, greatest benefit in stroke. And other classes, including alpha blockers, can be used under specific conditions, such as symptoms of benign prostatic hypertrophy. The other effects of hypertension drugs, like diuretics, beta blockers, can have dyschemic effect and dyslipidemia effect, so you'll have to be careful in using that. Combination therapy is advisable if the systolic BP is more than 20, diastolic is more than 10. And CCBs produce arteriovalve dilatation, ARBs produce decreased vascular volume and protects both arterial and venous dilatation. Combination is always good. Advantage of fixed doses, and then ABCD, you should not use beta blockers and diuretics and diabetics, and this is the algorithm. And conclusion, tight control was not associated with improved CV outcomes compared with usual control. Regardless of therapy, care or guidelines, targets will be achieved only if patients are motivated to stay on their treatment plan according to their healthy behaviors. Positive experiences, trust in the clinician, and empathy improve patient motivation and satisfaction. All guidelines serve as a guide, facilitate the physician's treatment decision on a case-by-case basis. Team care is important. As I advised, home BP monitoring you should advise. Glycemic control only is the focus. I see many patients, they come to me, they say, sir, my blood sugar is under control. They are not bothered about hypertension. So you must focus both glycemia and hypertension. Physician judgment remains paramount. That judgment depends on various factors on the disease and the patient. One BP goal or target may not suit all. So new ways of treating insulin resistance hold hope for counteracting both consequences and the concomitant cardiovascular risk. Diabetes is a growing problem. Hypertension is a growing problem. Hypertension and diabetes are dying problems. Hypertension is preventable. Never ever give up. And the control over his diet, takes regular exercise, has time to relax, does the right toil in discharge of his duties, observes proper hours of sleep, awakening, and is balanced in his actions and reactions, emotions and reasons, duties and rewards, conquers the disease. So learning is the beginning of health, learning is the beginning of wealth, learning is the beginning of spirituality. Thank you for your attention. Thank you very much. I think I finished on time.